Welcome to PRMC Study Guide. Today we're going to be talking about pulmonary embolism. This is going to be compiled from multiple different sources, most especially Life in the Fast Lane's website and Heavy Lights Helmets podcast, as well as Paul Wheeler, my mentor. We're going to start with the scenario. It is 7:45 and D shift is nowhere to be found. Bevo comes across the squelching radio, medic 48, need en route, 1301 Jackson, 50-year-old male, sudden chest pain, and dyspnea. Before we even go on the call, what's our thoughts? We're probably thinking angina. We've been on this guy 100 times. It's always this, and this. It's not a big deal. So, are you going to have lizard brain, or are you going to come in with an open clinical mind and a differential diagnosis? What would be your differential diagnosis? Pleurisy, maybe pneumonia, angina, he's depressed again. Is PE even on your clinical thought process? So you do a 12 lead, and this is what you see. Any ST elevation? No. Any ST depression? No. Nothing that like really blows your mind. Like this is a typical start an IV, give him aspirin, nitro, take him to the hospital, drop him off, let's go. Let's get off work. Nothing concerning. Or is there something concerning? Is OPQRST going to give you the answer? Is sample going to give you the answer to this question, to this EKG, to this patient? Probably not. So, a side piece. PE versus acute coronary syndrome. PE typically has tachycardia, whereas acute coronary syndrome typically does not. And when I found that stat, I looked back, I was like, it's not, I haven't had that many MIs that have been tachycardic. It is, at least in my experience, fairly rare. Outside of AFib, of course, you get that heart irritated, it tends to like to run out of control on those AFibers. But troponin levels. A PE can actually cause a troponin level, as can sepsis or dehydration or pretty much anything else that stresses the body out, because anything that stresses the body out stresses the heart out. So therefore, elevated troponin in this specific case is not saying 100%, oh, we have an AMI going on. It's saying we have cardiac stress going on, and we'll get into that a little bit later. So some characteristics of the PE EKG. S1, Q3, T3, mnemonic thing that is so unreliable, it's not even funny. Unfortunately, there's not a 100% specific, everybody with a PE is going to have this happening. In fact, 18% of PEs have a normal EKG. However, any patient presenting with signs of a right ventricular strain on their EKG should definitely perk up your ears and your questions. So what is right ventricular strain EKG characteristics? Well, right axis deviation is one. That's basically when the electrical pathway shifts to the right. So when you look at your axis on your 12 lead, that's going to be between 90 and 180. If you're between 90 and 180, that's right axis deviation. That's a sign of right ventricular strain. It's the change of the electrical axis of the heart, as well as a right bundle branch block, which a right bundle branch block, simplified, is go to V1, look at it, and if the QRS is greater than 0.12 milliseconds, and at the J point the QRS points up, that's right. It's a right bundle branch block. If it points down, it's a left bundle branch block. If you notice right there, V1, you see your T wave right here. The J point is right there. Points up, that's a right bundle branch block all day long. So right axis deviation, right bundle branch block, and T wave inversion, especially in leads 2, 3, AVF, V1, 2, and 3, plus or minus 4. If you get V4, that's just additional confirmation, but not 100% necessary. Those are signs of right ventricular strain. So if you have what I call the trifecta, right axis deviation, a right bundle branch block, and T wave inversion in those leads, 2, 3, AVF, and V1, 2, 3, and if I have 4, I'm really concerned. Those are all signs of the RV, the right ventricular, being strained, especially if it's a sudden onset. We're not talking about like this is a slow onset, gradually got worse. This is probably going to be more of a sudden onset, chest pain, dyspnea. You're probably going to be hypoxic. Not necessarily like, oh my God, they're in the 70s. It's probably going to be more like, 92, 91, 88. I have had PE patients who were in the 70s, don't get me wrong. But I do wonder how many I've missed because of their mild hypoxia. This should lead to a high suspicion of PE when you have all of those things come together. So here's another EKG. This is a massive bilateral pulmonary embolus. As you can see, we have the T-wave inversion in leads 3, V1, V2, V3, and V4, as well as lead 2. Notice there's no ST elevation. This is all affecting the right ventricle. The right ventricle is the one who is getting the stress. This is another massive bilateral pulmonary embolus. Notice that big, deep T-wave inversion going on. It almost, it's not hyperkalemia inverted, but it's very close to it to me. That's how I think about it. Like it's just a very big T-wave compared to that QRS, especially in those V1, V2, V3, and a little bit in V4 leads, as well as lead 3. Here's another example. I'll let you look at that one. This one's a little more subtle. You kind of have to look for it. There's a little bit of that T-wave inversion right there. V2 as well, V3. V4 is not really showing anything in this one, although it does look like they may have thrown a PVC during the V4 lead. Let's look at lead 3. Lead 3, man, it's subtle inversion right there. This one's a little bit tricky. This one is not really sure. What else could be causing that one? We'll talk about that in a second. And then here's our big saddle, our saddle embolus. That's just almost global T-wave depression. There's lead 3 inversion. V1 is really shaky. It looks slightly inverted. We have lead 2 inverted, AVF's inverted. That's a creepy EKG. But would you call that an MI? I would be tempted to say something's going on with the heart, but is it actually the heart or something else? So why does RV strain indicate PE. Is the problem the heart or the lungs? And why do patients go into cardiac arrest? Well, in a nutshell, when you throw a clot into your lungs, your right ventricle feeds blood into your pulmonary artery. Well, your right ventricle does not handle pressures very well. It usually handles pressures between 20 and 30. It's a bit of a diva. It's kind of the weak part of the heart. It's very irritable, and when you stress it out, it's going to be like Doug's septic system, and it's going to back up, and it's going to fail. And then that's how you get the purple from the nipple lineup. It just says, screw it, I'm done, and it fails. Well, if the right ventricle fails, it doesn't pump any blood through the lungs, which doesn't pump any blood through the left atrium, which doesn't pump any blood through the left ventricle. The left ventricle is a nice, big, tough muscle, and it can handle high pressures. You know, it's used to 80 to 100 pressures. So, right ventricular strain is a big deal. And very indicative of PE because it's a weak pump and it cannot handle the higher pressures. So, what is the treatment for a PE? As of right now, we don't have a treatment for EMS other than rapid recognition, rapid transport. There is a study out about nebulized nitro. It's promising. It makes sense. They're going to dilate the pulmonary artery, which will reduce the backload, preload stress on the right ventricle, hopefully saving the right ventricle from getting stressed out and just completely shutting itself off and failing. However, that has not been studied enough for us to be able to actually do that. So as of right now, rapid recognition is key. So hopefully, to put this in a nutshell, if you see right ventricular strain, does that mean PE? No, not at all. It just means the right ventricle is being stressed. So, and one thing too is the 12 lead is actually kind of good at figuring this out. They will note right ventricular hypertrophy. That's its favorite one I've seen. Is it just calls it right ventricular hypertrophy. It's not going to actually say right ventricular strain. But the diagnosis is made using ultrasound. They're going to put the ultrasound on the chest. They're going to see that, oh my goodness, that right ventricle is about to explode. Yes, this is a PE. Or they're going to be able to do chest x-rays and figure out other causes like severe pneumonia, pulmonary hypertension, cystic fibrosis, severe cases of asthma and COPD. At the end of the day, they're all caused. You have a very sick patient if you see this, because it's all caused by strain on the right ventricle. It's pulmonary hypertension and hypoxic vasoconstriction, and it's putting stress on the heart, especially the right ventricle. So to simplify the whole class into a nutshell, if you have T-wave inversion in the inferior and right precordial leads, 2, 3, AVF, V1, V2, V3, plus or minus 4, like I said, that is the most specific finding in favor of PE. In fact, some studies have actually reported as high as a 99% specificity. So, if you see this, then you should be thinking possible PE. Notice that they're not in a right bundle branch block. The T wave is the key. So let's just focus on the T wave. Let's make sure we're looking at those T waves and we don't take that T wave inversion for granted. And at least try to rule out possibility of a PE. And if that's too much to remember, your inferior and your right precordial, a negative T wave or inverted T wave in leads 3 and V1 have a sensitivity of 88%, a specificity of 97%, and a positive predictive value of PE of 95%. So all you have to remember is negative in 3, negative in 1. And my little scrambled brain that's full of ADD can remember negative T has a better than 3 to 1 odds it's a PE. That's my little mnemonic. Thank you very much.